Okay, thank you. My name is Josek Mageto from Kenyatta National Hospital. I'm glad to be here with you. Thank you for having me. Today, we are going to talk about multiple myeloma, and I'm going to share my slides. So if you're able to see my slides, I can just go ahead. So we're going to look into what is multiple myeloma to start with. So multiple myeloma is a malignancy of plasma cells. And we understand that it's second ranking malignancy among the hematological tumors. Now, it's second after non-Hodgkin lymphomas. One of the key underlying feature that we're going to look at is its characteristics. So multiple myeloma is characterized by monoclonal proliferation of plasma cells. And with that, there is production of monoclonal antibodies, which leads to end organ damage. Now, we understand that plasma cells are mature antibody-producing B cells, and they are found in the bone marrow. They are essential in adaptive immunity. So there is this image here that shows us what how the whole process begins and how it ends up into multiple myeloma. So the team of Mikhail and group have made an illustration. Now, there are so many activities that go into the cell, that is a B cell, in order for it to transform into a malignant plasma cell. So we understand that there are chromosomal translocations that go into it. There is cytogenetic abnormalities that go into the pathology and the pathogenesis of this condition. So what do we know about immune cells we call B cells? Now, when a pathogen attacks our bodies, the first barrier it gets is the anatomic barrier. So the anatomic barrier is supposed to fend off all the pathogens. But once the pathogen has breached the anatomic barrier, we find that an infection develops. So when an infection develops, there are components in plasma. Some of them we call the complement system that are able to attack the pathogen and let it lyse and die. However, when that is not put in right perspective, there are some effector cells of course, of the immune system that will also identify parts of that pathogen, what we call the pathogen-associated molecular patterns. So that system could also be breached, and it takes almost 24 hours. By the time you're in 46 hours of the infection, now you have to induce the adaptive immune response. And this is when the antigen now from the pathogen is transported to the lymph nodes or the lymphoid tissues. And in the lymphoid tissues, this is where we find the B cells and the T cells. The B cells are specialized in a manner that they have special receptors, what we call the B cell receptors, that are able to identify these pathogens, and they start what we call monoclonal clonal expansion. So it means that specific antigen receptor, when it gets into contact with this antigen, it expands that clone only. So you have a lot of specificity to specific antigens that attack our body. That way, that is the beginning of the development of a plasma cell. Now, a plasma cell secretes antibodies that are specific for a specific antigen. However, in the malignant plasma cells produces only one type of these antibodies, meaning they are not able now to fend off the infections. That's what we call the M protein. There's an illustration here of an immunoglobulin, which is also called an antibody. The unique thing about it, it has the heavy chain and the light chain. This specific molecule takes part in the pathogenesis of multiple myeloma, in that the monoclonal, the malignant plasma cell may end up producing one specific type of either the immunoglobulins or free light chains in the system. Now, the antibodies are very unique. They have two identical heavy chains, which are of 5 different types: the IgG, IgA, IgM, IgD, and IgE. We find that the commonest is IgG in this condition we call multiple myeloma. But the IgG could have the light chains of either kappa or lambda nature. Now, when the disease has formed, we find that the myeloma cells, they have the ability to do several things. One is to spread or grow into a mass. And this mass could be within the bone or outside the bone, what we call a plasmacytoma. And they could produce only light chains and not the whole antibody. Could be either kappa or lambda. And these ones are unique because they are tested and they could be identified through laboratory tests. Now, a condition sets in we call light chain amyloidosis, whereby we find now the light chains are abnormally folded, and therefore they are not able to be filtered through the kidneys, and they end up causing end organ damage, a condition we call amyloidosis. Now, some of the data we have concerning multiple myeloma is that incidences that have been found, especially with the global can in the year 2020, we found out that there were approximately 176 new cases identified. But approximately 0.05 were from Africa. And of all these cases, 53.4% were males and 46 females. But also globally, we find that 117 cases of deaths were recorded in the year 2020. Out of these, 0.05 were from Africa. So according to SIA registry, they estimated 34,000 cases, new cases of multiple myeloma, that is in the US, and 13,000 deaths. And therefore that brings us to an incidence of approximately 7 in 100,000 males. That is relatively high. So there is also data that multiple myeloma is slightly common in males than females. And the age at diagnosis, median age at diagnosis is at 66 years. But for only 10%, and 40 years, around 40 years, it is 2%, according to Okello and group. The risk factors for multiple myeloma, we find that this is a neoplasm of older adults. And some studies, according to Padala and group, they found out that the median age was at 69. But basically, we now know that it's above 65 years, according to various studies and various places they were conducted. And deaths occur from age 75 and above. So we also learning that it is common amongst males, as we have already identified, but it's not very clear why males are more prone to multiple myeloma than females. However, even are more likely to engage in smoking and alcohol consumption and high rates of obesity, but that is unproven when it comes to the condition of multiple myeloma. The rest, African Americans, there's a high incidence of 16.5 in 100,000 persons, compared to the Caucasians, which is 8.2 in 100,000 persons. So what is unique here is that African Americans have a younger onset of disease on average. So family history, we also have data that the first degree relatives are more prone to this disease compared to maybe other people in the community. So therefore, it could be in the family genetic history. And body mass index, we find that increase in body mass index will predispose you more to this condition. So finally, on the clinical presentations, the signs and symptoms of multiple myeloma are related to two things. One, the infiltration of plasma cells into the bone and other organs. Two, kidney damage from immunoglobulins that are deposited in the kidney. Now, this is very unique because there is an acronym called CRAB. And as it is highlighted here by Michael and group, that is a multiple myeloma defining signs and symptoms. So this is when a client has hyperkalemia, renal insufficiency, anemia, and bone lesions. However, we know that more than these four, we have others that are related to this condition. One of it is weight loss, up to 10 kgs above what somebody had previously. We have fatigue that comes in. That could be related to anemia, but fatigue is also very common. Bone pain. We have repeated infections, the bruisability and bleeding, and the neuropathy. So there are other symptoms up and on top of the common four that we know. Looking into anemia, we find that anemia clearly simply defined as a hemoglobin level of 2 grams per deciliter below the normal lower limit. And therefore, mostly we'll find the normocytic, normochromic anemia in most of these patients. Actually, 70% of them at diagnosis and 95% in the course of treatment. And these are patients who will just present with complaints of fatigue, pallor that is seen during physical examination. But also, this anemia may reflect the bone marrow replacement by these plasma, malignant plasma cells, erythropoietin deficiency due to kidney damage, and also hemodilution due to a large amount of proteins in circulation. We will also find bone pain amongst these patients. So osteolytic bone pain or bone disease will cause a lot of pain. And to some clients, they will present with fractures. So this one will be identified during a skeletal radiograph, CT scan, or FDG PET. And there is that diagnosis when you want to make a diagnosis of osteolytic bone lesions. However, the commonest site is the central skeleton. So these are clients who complain of back pain, neck pain, shoulder, pelvis, and hips. That is very common, more than the extremities. The pain is less common at night because it's often induced by a movement. And some clients some will start reducing in height. This is because of vertebral collapse. And some pain may reflect plasmacytoma in specific regions of the body. Kidney disease, when these patients are checked, you will find that the established GFR is below 60 ml per minute per 1.73 square meters. And therefore, two major causes of kidney impairment will lead to a kidney disease in multiple myeloma patients. The light chain casts that will deposit themselves in the kidney, what we call a myeloma kidney, and also hypercalcemia. So when you have above 0.25 millimoles per liter, higher than the upper limit of normal calcium levels. And therefore, patients who do not secrete light chain, the light chain chains of these antibodies are at low risk of developing a myeloma kidney. So just drawing to the close, neurological diseases or signs and symptoms are rare in multiple myeloma. However, though rare, they require urgent evaluation for metastatic spinal cord compression and hyperviscosity. So sometimes you could find extradural spinal compression of the plasmacytomas that will present with weaknesses, paresthesia of the extremities, bladder and bowel dysfunction, and incontinence. But we may also find a patient presenting with oronasal bleeding, blurry vision, confusion, and heart failure as one of the signs that is associated with hyperviscosity. This is because of the immunoglobulin that are in circulation. Sometimes patients may present with the CNS involvement, whereby this patient, the brain parenchyma is affected because of a brain lesion, myelomatous lesion in the skull, or a plasmacytoma at the base of the skull. So finally, this patient may present with infections, and therefore this is because of the impaired lymphocyte function, as we saw from the beginning, also suppression of the normal plasma cell functions. And therefore, the other symptoms, finally, you may find in such patients is weight loss, over 9 kgs in a short duration of time, and hepatomegaly, splenomegaly, and lymphadenopathy, and also fever may also be a presenting symptom. So those are my references, and I thank you all for listening.
Thank you very much. That was fantastic, fantastic, Joseph Margetto. We really appreciate that overview that you have provided. It has really helped us to conceptualize what the topic is all about. Multiple myeloma is quite available. I can see claps, I can see hearts going on. I think everybody is really appreciating the overview that you've provided, because it sort of gives us an opening to the day-to-day to help us now conceptualize the whole topic. And I think that was the best way to start, because we have a short overview that has helped us understand what the topic is all about. And then now we can have an opportunity to listen to Mr. Matthew Toom. He is a multiple myeloma cancer survivor. He is going to share his story. He's going to talk to us and enable us to know what was the journey like, what has he gone through, what are some of the treatments he's had, and then thereafter we'll crown it all by having the specialist, Dr. Melly, take us through now the clinical aspects of it, which will help us really conceptualize the topic. So welcome, Matthew Toom. I can see you're now online, and I can see you're unmuted. Welcome.
Thank you. Can you hear me?
Yes, we can, Matthew. Kindly go ahead.
Okay, thank you very much. Matthew Toom, multiple myeloma warrior. My hospital number is 0127803. I appreciate this opportunity given to me to present my journey since I got this condition of multiple myeloma. At this juncture, may I take this opportunity to thank God for keeping me healthy to date. I pray for long life. I thank all the doctors and the entire hospital of Moi Teaching and Referral Hospital and other health facilities for trying to give us proper medication. My journey began at the end of the year 2011 when I felt lower back pain. In the course of 2012, it became worse. I sought various treatment, for example, massage and painkillers. At the end of 2012, I was admitted in St. Luke Hospital on 3rd of November 2012, where I met Dr. Lele, among others. Various tests were done, for example, biopsy, blood tests, but the results delayed from Lancet. That is when I was discharged to be checking for the results. The results never came. The following year, 2013, I was taken to Kenyatta Hospital for tests, of which I was admitted at Nairobi South Sea Medical Center. I was assisted by Dr. Kikenya between 31st of January 2013 to 10th of January 2013. Here I was diagnosed with multiple myeloma, which I was told the bones could not make good blood. Hence, I was given drug prescription. The first one I was given was melphalan. Later, I was changed to thalidomide, and lately I was given lenalidomide, plus now bortezomib. After discharge, I was referred to Eldoret Referral Hospital from Nairobi, where doctors, Dr. Chita received me. Later on, Dr. Cosmas, Dr. Melly, Mercy of pharmacy, doctors of Lorraine, clinicians, for example, Austin, among others, who encouraged us about the condition. My health improved greatly and reported back to work within 3 months of medication. I've had several drug breaks after the tests were done that I was negative or zero, maybe multiple myeloma cells or proteins. I'm now on break currently, and I commend the MTRH staff for their hard work in spite of increasing patients in the facility. I urge them to continue serving us, and some are an example in the journey we are in of having this condition of multiple myeloma. So we are normally encouraged by them in the morning before we get treatment. I'm currently performing normal duties, and no one may realize the health condition which I am in. I request that if there could be a way of finding stem cell in a cheaper way, so for us, so that we may heal completely from this condition of multiple myeloma. We thank God for this far. I thank my family and colleagues who assisted me at that difficult time of this condition, or beginning of this condition before diagnosis. But after diagnosis, I have been feeling much better. I'm encouraged. The way I feel the body is working, I'm really encouraged. And of late, maybe we can see some challenges cropping in because of changes in the country, policies, and so on. First, I'm a teacher by profession. Teachers are disadvantaged because of NHI regulation or policy which came into force in January this year, 2023. Only 10% of the medication is approved, whereas Merkel is not connected at MTRH. We request that we follow it, you follow it for us if possible, so that Merkel, that was our own, to join up with NHIF so that they fill the gap, because topping up 90% every month is a challenge to some of us with maybe little salary because of commitment of other issues. That is challenge number one. Number two, some drugs, for example, lenalidomide, sometimes delay, hence you miss medication for some time. Another challenge is about some protocols followed in the hospital, hanging systems delay patients, which lead to congestion and end the process taking 2 days, which becomes costly to the family. We hope NHIF systems and protocols are improved for efficiency of treatment of the patient, so that there is no backlog or delay in the queues or the long queues. We have some persistent side effects in the body as per the use of the medication. For example, numbness of the feet and hands. Sometimes you have diarrhea when you use bortezomib. And also, we could also not miss to have the fear of stigmatization, which the society knows this condition. They realize it is a kind of cancer, and they sympathize with the patient. They cannot empathize, but sympathize with the patient. Otherwise, for now, I want to say I'm feeling 90% working condition. And we really want to thank everyone who has actually collaborated, right from our doctors, service providers, and maybe the family. And in the forefront, we want to thank God for this fact. I, for one, appreciate so much such an opportunity, and to be heard by you doctors, so that you can actually improve our services for better and long life. Thank you.
Thank you very much, Mr. Tum. I think he deserves a round of applause for him to speak with us, to share his journey. We've really benefited, and there is the round of applause, Mr. Toom. You can be able to look at the screen and you'll see the participants. You've had about 1,489 participants who have really appreciated you sharing your journey. It helps us conceptualize what we are discussing. It helps us think about it. It helps us understand from the perspective of the patient how things have been. And we really appreciate the fact that you have gone through with the journey, have not stopped with the treatment, and that really makes us happy. So thank you very much, Mr. Toom. Thank you, thank you, thank you. So for now, we will move. We'll have Dr. Beatrice Jepngetich-Merli. As I mentioned, she's a consultant clinical hematologist at the AMPATH, that is in MTRH, and she has a vast experience dealing with patients. Her compassion and care for patients is unmatched, and we're really pleased to have her today so that she can be able to take us through the journey, to give us an indication of what we should do and how we should manage. So hers will be an overview. I'll be sharing the screen, the overview of multiple myeloma. Karibu sana daktari.
Thank you very much, Dr. Wanda. Are you able to hear me?
Yes, we can. Yes, we can hear you, daktari.
Thank you very much for this opportunity. Are you able? I think I'm sharing my screen. Are you able to see?
Yes, we can see your screen.
Thank you. I'm sorry I joined a little late. I was having some issues with my internet. I also want to thank KENCO for this opportunity that they've given us to just continue demystifying our management of multiple myeloma. Thank you also, Joseph, and for sharing with us basically how a multiple myeloma patient presents. And thank you, Matthew, for sharing with us the experience of the typical experience of a multiple myeloma client as they go through this treatment process and the challenges that they face. I'm going to quickly just take us through and some of the, I might repeat a few things that that Joseph has mentioned. And basically what I want to take us through is the overview, or the overview that we are going to go through is the AMPATH multiple myeloma program here in Moi Teaching and Referral Hospital. Run through multiple myeloma as a disease, and then just one slide on multiple myeloma project ECHO. The AMPATH multiple myeloma program is a program that was established more than a decade ago, and the main objective of this program was to basically try and identify where these clients were, and once we've been able to find them, we would be able to offer treatment and basically try and retain them in care, and at the end of the day, improve the care for multiple myeloma. It has 4 main pillars, and this basically is the primary objective is clinical care, where we seek to once this a client who there's a possibility that this client has multiple myeloma has been referred to the program, we investigate this client and work towards getting a diagnosis, and treatment, and then follow them up. The program also offers patient support. You heard the story from Matthew of the challenges towards diagnosis, and even the treatment process. It's very expensive. You heard that he's a teacher, and you may find that they are not fully supported in terms of sustainability of treatment. So the program does offer support in that. Sometimes pays for their bone marrow aspirates, sometimes it will pay for some lab investigations that are required, and then at the same time support NHIF, especially clients who do not have NHIF, we register them. It also reimburses transport because many times they have to come in for their clinic visits or even their scheduled injections. And then the program also, over the years, has supported in development of a support group. And through this support group, patients enrich to one another, share their experiences, and basically organize the group in a way in which they are able to learn from one another and even become champions and advocates. There's also training and awareness creation as a third pillar, and this also has been going on over the past year.
Sorry, Dr.
Hello.
Melly, your slides are not moving. I was wondering whether you could put it on slide share, like a complete page, so that we can see the slides moving.
We are on slideshow. I'm still on slide number 1.
Oh, it's not on complete slide share. On our vision, we're seeing it we are actually seeing the side.
Okay, let me try that again. Is that better?
Okay. Are you able to put it on slide share, like full screen? Slideshow, the show? Sorry, Dr. Sorry about that.
Is that, how is that?
At the, okay, I don't know, the total bottom of the page, there should be somewhere you can put a slideshow so that we can see the full screen.
Okay, so because I've clicked on the slideshow and then that's the slideshow.
Okay, Dr. Then maybe you can proceed.
You could still share from your slide if it's a problem.
Okay,
If it's
let me do that. Yes, Doc.
Okay.
Yeah, is that, I hope you can see my slides now. Can you see the slides?
Yeah.
Okay.
I was in slide number 2. Go to next slide, Dr. Thank you. So I was talking about training and awareness creation, and this one we have been doing a training for healthcare providers and community health workers, and we've been reaching out to the counties that refer to Moi Teaching and Referral Hospital, which is about 22 counties. As it is right now, we have reached 18 counties. We have just a few more to go. And basically, the idea has been to educate healthcare providers, because for you to think about multiple myeloma, you have to have a high index of suspicion, and that's usually the challenge in the diagnostic process of multiple myeloma. We don't think about it when the patient comes to the clinic, and that delays the process of diagnosis. And our objective for reaching out to the community healthcare workers has been so that also the community are aware about this, and we can be able to create the impetus in them to be able to seek healthcare and also think about the possibility of maybe what a community member is experiencing, that it could be multiple myeloma. We also disseminate information through research, publications, presentations, and also social media. And basically, this is also a platform that we've been given to be able to talk about multiple myeloma. That's a number that you can be able to reach to the AMPATH Multiple Myeloma Program. Next slide. Next slide, Dr. Thank you. I think you jumped. Go back. Thank you. So this is also just to show us what has been happening over the years. And you can see when the program began in 2012, the program only was able to pick about 12 patients. And if you look at the tail end in 2022, we had about 56 patients. but you can see that the graph has been going up over the years. And we attribute this to continuous dissemination of information, just generally improvement of health-seeking behavior within our community, and also improvement of the diagnostics and the high index of suspicion. You can see even during COVID in 2020, still we diagnosed quite a number of patients. In 2022, you can see the graph dropping a bit. And we think in our healthcare training process, we've been empowering the counties, and we've even started now sending patients back to the counties, for example, for their weekly injections. And then some county referrals actually have now developed oncology centers, and therefore they are not necessarily referring to us anymore. And some of them probably just come in for their monthly hematology reviews. So capacity is improving, but this is still not enough. More needs to be done in terms of, when you look at the total number, which is not captured here, over the past decade, we've had almost more than 500 patients transitioning through the program. Next slide. This next slide just shows the distribution of newly diagnosed multiple myeloma patients in 2021 and 2022. And this is just for us to appreciate the age in which this multiple myeloma is diagnosed, even in our setting. You can see less than 40 years is 7 and 4 for 2021 and 2022. But you can see the peak. The peak is between 60 to 69 years of age, which is not too far actually from even from what is happening in the rest of the world. It's a diagnosis of the older population, but that means that also these can be diagnosed in a younger population. From our clinic experience, we are seeing younger and younger patients. We are seeing more patients in their 40s. And our youngest patient was actually diagnosed at 26 years of age. Currently, he's in his 30s. And I think it's just for us to appreciate that, yes, it's a disease of the older population, but then at the same time, you need to open up your diagnosis and not necessarily lock your mind that it is just a disease of the older population. Next slide. This next slide shows the distribution of newly diagnosed patients in the counties that we have reached out. This is about all the counties that are referring to MTRH. You can see high on the list is Uasin Gishu County. And but I think this is mainly because the catchment area for Moi Teaching and Referral is within Uasin Gishu County. So, but that doesn't mean that the patients, most myeloma patients live within Uasin Gishu County. Actually, you could as well just translate this number for Uasin Gishu County in all these other counties that you can be able to see here, and it will probably be the same number. And we are talking these counties referring to still this could mean that there are many patients actually who we are not picking. There are patients who they are not being diagnosed, and they are probably succumbing to this disease without them being diagnosed. So, and that is why we are continuing to partner together to be able to talk about it and disseminate information so that our index of suspicion for multiple myeloma can increase. Next slide. So just to, thank you. This is a graph of the multiple myeloma patients so we are looking at the number of clients who are sent to be screened for multiple myeloma, and this was in 2021. So when you look, in 2022, sorry. So when you look at this, the blue line, we about 206 clients. This is between 2021 to 2022. When you look at the blue line, the total number of clients who were sent to us for a possible diagnosis of multiple myeloma was almost 200 patients, and out of those, about 130, which is actually more than half of them, ended up having multiple myeloma. And then, unfortunately, when you look at those who are alive at the end of 2022, there were 81, and those who are deceased were 49. So we are talking about almost close to 50%, actually a little bit more than 50% mortality. So, and those are the questions we are asking ourselves. Yes, we are also still improving on our diagnosis, but at the same time, even after we diagnose, at what point are we diagnosing these patients? Are they coming in late, so that even when we are initiating our treatment, it is a little bit late in terms of your intervention, so that we are losing a significant number of them. At the same time, we've introduced treatment, but then there's also disease progression in terms of those who already initiated treatment. When the disease has progressed, did we optimize our first line treatment for these clients? And then at the same time, what are our second line options for these clients? That is a challenge, which I think also was captured by Michael, that it is not just about bringing diagnosing it, but at the same time, the options of treatment that are available should be able to be as close as what is happening in other, let's say, advanced countries. Next slide. So we are going to, next slide, please. I'm going to briefly go through multiple myeloma now. Next slide, Doctor, it's not moving. Dr. Wanda?
Are you able to see the slides?
It's still stuck on the slide I was on. Next slide. I want now to talk about multiple myeloma. Thank you. Multiple myeloma, and I think Joseph went through this brief, actually fairly elaborate. It's a disease that comes from the lymphocytes, and specifically the B cells. It's a B cell malignancy, and what happens here is you have an excess production or an abnormal proliferation of plasma cells. And the plasma cell is the most mature form of the lymphocytes. And basically what happens is that you have a single plasma cell that has undergone some genetic aberrations, some genetic changes. We know that the cells in the body are constantly dividing, and there are genetic mutations that are happening real time, and sometimes mistakes happen in those genetics, and but ideally they should be automatically corrected. But when that ability to correct fails, then you may now have new cells acquiring a new characteristic of cloning itself. So you have this plasma cell that starts cloning itself and repeatedly producing itself. And then the unique thing also about the plasma cells is that it produces what you call immunoglobulins. And these immunoglobulins, you will have an excess of it in either in blood or also an excess of it in urine. Also for multiple myeloma, there is a premalignant stage, and I think this is important for us to appreciate. We have a stage called the monoclonal gammopathy of undetermined significance, and also smoldering myeloma. And sorry, the slides are moving a bit faster. So can we go back? So when you talk about monoclonal gammopathy of undetermined significance and smoldering multiple myeloma, it looks at the presence. Actually, go back to the previous slide. It looks at the percentage of plasma cells. It also looks at the levels of the immunoglobulin, and then at the same time, it looks at the presence or absence of end organ damage. So you'll find that in smoldering multiple myeloma, in smoldering myeloma, can I go back to this previous slide?
Sorry, the slides are moving.
The slides are moving.
Okay, let me stop the share. Let me share again. So
that probably as you're sharing, when you talk about monoclonal gammopathy of undetermined significance and the smoldering myeloma, it looks at those levels that I had mentioned, and usually there's absence of end organ damage, and then it looks at the level of immunoglobulin, whether, for example, for monoclonal gammopathy of undetermined significance, it is less than 3 grams per liter, and at the same time, percentage of plasma cells of less than 10%, and absence of end organ damage. While that of smoldering myeloma, it is a plasma cell of more than 10%. Also, the levels of proteins are more than 3 grams per liter, but there's still absence of end organ damage. Why this is important is that there's an approximate rate of this transitioning to a full-blown multiple myeloma, about 1% per year. And there are even interventions that have gone to make a decision whether there should be intervention at that level. So we are hoping that even as we talk about multiple myeloma, we seek to improve until we are able to pick this disease at the pre-malignant stage, instead of picking it when the patient has come with a full-blown disease. The multiple myeloma is basically a systemic disease, but you can also have where you have a single area being involved, or a single area in the body, or a single bone area, and that one is called a plasmacytoma, as opposed to where you have multiple bones involvement or second involvement, which is multiple myeloma. My slide are still not shared, actually. I'm sorry for that.
You see the slides now?
It's just viewing your screen, but they are not on our screen.
How about now?
No, maybe another colleague can confirm if they are seeing on their end. I'm not seeing on my end.
Is anyone else seeing the slide? Sorry, we need to confirm that.
I've tried sharing on my end also.
Yes, we can see your slides. They're just
Okay.
not on full screen, but you can proceed.
I'm sorry about that. I think, yeah, I think we'll just continue like that.
Okay.
Okay, so I will move to how the epidemiology of multiple myeloma. And we need to appreciate that actually multiple myeloma is on the rise throughout the world. These are just the countries that have been able to pick. They're better at picking the data. it would be difficult to say, is it increasing on our end or not? And I think we need to do a better job of our registries. But I think from the slide that I presented, you saw that actually we had an increasing number of diagnoses of multiple myeloma over the years. It accounts for about 2% of all cancer diagnoses. But when you look at within hematology, it is actually the second commonest hematological malignancy after lymphomas. In other settings, lymphomas and leukemias come in, and then it comes in as third. And if you walk into a hematology center, you definitely not miss to meet a multiple myeloma client. So yes, it is less common when you look at all cancers, but in terms of the experience, just within hematology, it is actually a common disease, and the incidence has been rising globally, over 126%, and in the US more than 40%, and in the rest of the world, actually, the mortalities are going up. We saw that our mortality was going up, but in the US, you see it is falling, and I think this may be involved by access to novel agents. It's also important to appreciate about the 5-year survival, and this is just from the US. It has doubled over the past decades, and then with the introduction of these targeted therapies, and then transplant as an option of treatment. And that's why we are also continuing to speak about this, so that we can be able to assess what are our access to these targeted therapies and transplant options. Yeah, so when you look at the risk factors for and this also Joseph had mentioned, he talked about age, which is actually really the older age, more common in blacks. I will just run through this, and then more common in male than female, and then just a preponderance in family history, but not really that significant. And then if you've had other plasma cell dyscrasias, the risk, for example, now the pre-malignant stages that you were talking about, the risk of you developing multiple myeloma is very high. And then history of exposure to radiation, and then other lifestyle conditions like obesity. So so when you look at the pathophysiology of multiple myeloma, and I think I'll spend a little bit of time here so that we are able to understand how this impacts in our body. When you look on just in terms of we talk about a clone of cells. Basically, this population of cells is increasing in number in the bone marrow, and you see in the bone marrow there are other cells that are also members of that bone marrow. You have your white blood cells, your red blood cells, and the platelets. So if a particular cell has decided that, you know, I'm just replicating myself, then it basically infiltrates the bone marrow, and then impacts the production of other cell lines. You will have development of low platelets, or what you call thrombocytopenia, and in that, because now that pool of cells are not able to expand appropriately, and therefore the patient may come with bleeding. And then at the same time, even though the plasma cell is a part of the white blood cell, which play an important role in the immune system, the other production of the white blood cells, other white blood cells are affected. Therefore, this patient will come with neutropenia and history of recurrent infections.
Sorry, Dr. Melly, your slide, we are still at epidemiology. It's not moving.
The slides are not favoring me today.
You can let Kenneth research go on, proceed. They're sharing the screen. We are seeing, yeah, maybe Kenneth research, you can go to the next slide.
Are we now on the slide for pathophysiology?
Yes, we are the slide for pathophysiology. I think we're sharing the screen for you.
Oh.
Yes.
Just a minute. Okay. But I'm not seeing the screen. what I'll do, Dr.
Yes,
because I'm not able to, if members can be able to see on your end,
yes,
I will just say move the slides and then I present
no problem, Dr. We
my
can be able
phone.
to see it on full screen now. Thanks.
Thank you. So I am on the pathophysiology slide. So, and we are talking about bone marrow infiltration. So you will present with bleeding diastasis because of platelets have been affected, and then neutropenia where you will have infections, and then at the same time red blood cells are affected. So this patient may present with anemia. At the same time, we talked about the plasma cells usually produce an immunoglobulin. So if you have an excess production of plasma cells, then you will have high levels of this immunoglobulin being produced. And basically what happens now is you will have blood being heavy, and Joseph had mentioned about viscosity, and he went through that very well. At the same time, this paraprotein gets deposited on the kidney and may cause even acute tubular necrosis. The patients may present with signs and symptoms of kidney failure. And then at the same time, the viscosity also might be clamping on the platelets, and at the same time increase the risk of bleeding diastasis. At the same time, you have bone marrow destruction. And Matthew had mentioned that he came with back pain, which is possible that the multiple myeloma was actually affecting his bones. Basically, these cells, the plasma cells, they cause an imbalance between the process of bone formation and bone destruction, and cause weakening of the bones, and therefore you may have a fracture, what you call a pathological fracture. Basically is a fracture that necessarily happens without a significant force. And then at the same time, because of that process of bone resorption, calcium is a component of bone, and therefore the calcium comes out and starts circulating in the system, and then you'll have signs and symptoms of what you call hypercalcemia. And then the same high levels of calcium might even cause more bone problems. So basically, there are three major ways. You will have bone destruction, at the same time bone infiltration, and then this paraprotein. So move to signs and symptoms, which basically I have gone through, and we talk about the famous CRAB symptoms, where you have high levels of calcium. So patients may present with signs of dehydration, some kidney issues, and then at the same time signs and symptoms of anemia, which is usually fatigue, dizziness, and then bone pain. Actually, bone pain is one of the big presenting symptoms. And then besides that, in some instances, actually, patients may present with signs and symptoms of spinal cord compression. And you can have what you call impending, and then you can have, where you actually now have a spinal cord which has been compressed. And if you're in the clinic, the patient will tell you, I have pins and needles which are pricking me, things like my feet are hot, and I have back pain. That could be a sign of impending cord compression. And your role as the clinician there is to be able to pick that early, because you'll be able to make a difference between that patient walking and probably being confined to a wheelchair. So I've talked about peripheral neuropathy, which is just pins and needles. This is a high metabolic state disease, and therefore patients present with weight loss. And then recurrent infections that we were talking about. And then you may now have also patients presenting with a swelling it can be a swelling in the eye, in the chest, in any part of the body actually, and that might have the possibility of being a plasmacytoma. So the next slide just shows the pictures of lytic lesions, and I hope you are there, Dr. because I'm not able to see the slides. You can see there a skull, and then at the same time there is a humerus there, and with actually a fracture and an attempt, I think it's attempting to form bone. Yeah, that's just an example of the lytic lesions. But so when we move to diagnosis, are we on the diagnosis slide?
Next slide, please.
diagnosis.
Yes, Doc, we're on this slide on diagnosis.
Thank you. So for diagnosis of multiple myeloma, there are basic tests that you start with, and then you continue escalating. Basically, you start with a complete blood count together with a peripheral blood film, and for the complete blood count, you're looking for any cytopenias. It can be anemia, which is usually normocytic, normochromic, and then and you can also have low white blood cells, and you can also have low platelets. So you need just to keep an open mind, but anemia is the big one. And then a peripheral blood film, very important. I cannot emphasize the importance for this. And for any CBC that you see that is abnormal, always request for a peripheral blood film, because it might just be the only guide towards the diagnosis of multiple myeloma. This is a message that we speak even to our emergency departments, that when patients come in and they have any cytopenias, they request for a peripheral blood film. So you'll see what you call rouleau formation, which we'll just see a picture down in one of the slides, where the cells are sticking to one another. The red blood cells, and the reason why they are sticking to one another is because of the excess immunoglobulin that we were talking about. And then chemistries, where you're going to do the kidney function, and creatinine, urea, which might be elevated, your calcium levels, which might be elevated. We talked about hypercalcemia, and then after that, there are more tests that you can you do to now assess the presence of this protein, excess of protein. There's a test called serum protein electrophoresis, which basically looks at the proteins in the body, which the highest is albumin, and then we have other proteins. Alpha 1, alpha 2, and then beta and the gamma globulins. And if you see a peak, usually, even if you're not able to read anything, because that sometimes it's a challenge to interpret, if you the only peak in that graph is usually the albumin. If you see a second peak, and you will see that picture, then the possibility that that patient has multiple myeloma. But usually our hematopathology team can be able to give you even a specific value of the immunoglobulin that is elevated. Apart from that, serum protein electrophoresis, you can do a serum free light chain assay. You know that an immunoglobulin has actually a heavy chain and a light chains, and you can have a type of multiple myeloma where actually it's a light chain multiple myeloma only, and some of it may be excreted in urine. We know the famous Bence-Jones protein, and I know some of our facilities, probably the only guide towards this that they have is the Bence-Jones protein. Actually, the Bence-Jones proteins are light proteins, light chain proteins that are being picked in urine. It does not diagnose it, it's just a screening test. And actually, not all myelomas are secreting this light chain. So it does not necessarily, it could just be a screening test. So you can do serum free light chain assay, and it will tell you the light chains, kappa and lambda. And if you have a skewed ratio where because usually multiple myeloma would be restricted to one light chain. It is either, for example, when you talk about immunoglobulins, it can either, for example, be an IgG kappa type, or an IgG lambda type, and therefore, when you have a serum free light chain assay, you will get a skewed ratio. And then besides that, you can do a serum immunofixation. And serum immunofixation, basically what it does is it will tell you which immunoglobulin is elevated. You know all the immunoglobulins that we have, IgG, IgG. To tell you the specific type of immunoglobulin during electrophoresis and immunofixation, because I'd say that these same immunoglobulins, especially the light chains, can be secreted in urine. So besides that, there is now the bone marrow aspirate. And bone marrow aspirate is very important towards the diagnosis of multiple myeloma. We are going to look at the percentage of plasma cells in this bone marrow. it should be, usually the normal percentage is about 2 to 3%. And if you get plasma cells of more than 10%, either in the bone marrow or in the solid mass that you had palpated and you've taken a sample from there, if it is more than 10% then of plasma cells, then that is there is a possibility of it being multiple myeloma. Of importance is you have to be able to define. Before I talk about defining the clonality, it is when you're doing a bone marrow, always do the bone marrow together with a trephine biopsy, because sometimes you can do aspirates and the aspirate is not able to give you information. It could be hemodilute. So it is very important. And then you see, it is also costly to come and repeat, not just cost-wise, but also it is also a painful procedure. So though we try as much as possible to give good anesthesia, but still many times a patient may experience pain and they usually don't want to repeat that. So in that one sitting, and this is the message we've been taking to the counties, that when you go for the healthcare provider training, we also do demonstrations for the bone marrow aspirates and also continue capacity building. That you have to do both at the same time. Many times we have patients who are referred to us, and you find that maybe it is an aspirate that was done only, and then we have to come and repeat the aspirate and the trephine biopsy again. And sometimes in an aspirate, and I know hematopathology would really support this, you may the clone of plasma cells might be in a specific microenvironment where the aspirate process will miss. Now, when talking about plasma cells, it is not just more than 10%. It should be more than 10%, and then it should be a clone of cells. So when you're talking about a clone of cells, these cells ideally should, in other words, a clone means that these cells are looking alike. And how do you define clonality? After you can define it by from this trephine biopsy. That's why I cannot overemphasize the importance of doing a trephine biopsy. You can do what you call immunohistochemistry on the trephine biopsy, where they do further testing. They do CD markers, CD138, which will tell you that it is plasma cells. But besides that, they do also the kappa and lambda on it, and the kappa and lambda will tell you whether it is kappa restricted or lambda restricted. Now, that is at the point where you appreciate clonality. Besides that, also when you do the serum free light chain assay, it will tell if it is giving you a skewed ratio. That also defines clonality. Besides that, also now, apart from the bone marrow, you do radiological survey. In the past, we've been doing skeletal surveys from head to toe, but we've slowly moved away from that. I know quite a number of county referrals have access to CT scans, and you can actually do a full body CT scan. And then at the same time, you can do PET scans. I know PET scan is available now in a number of private facilities in Nairobi, but the one that is supported by NHIF is Kenyatta University Teaching and Referral Hospital. And we've been referring patients there to do their PET scans, which if they're able to do baseline, it is very good so that you can do an assessment at the end of treatment. And you can also do MRI. So you have actually several options. This is important because sometimes you may have a patient, for example, who, let's say this patient, you find them at the premalignant stage, at the smoldering myeloma that we talk about. If that patient is sent for CT scan and for MRI, and you pick a focal lesion, that patient immediately transforms to a patient who will require treatment. I need to move faster. So we move to, that is just a picture of an SPEC. Next slide. So you can, and then the next slide is rouleau formation. You can see the cells are sticking to one another. Next slide. This is, for you to diagnose multiple myeloma, there's a criteria that is important for you to follow. You look at the clone of plasma cells that we mentioned, it should be more than 10%. That is why a bone marrow aspirate is important, together with the trephine biopsy, or an extramedullary mass where you took the biopsy from. And then you need that one, and then any of the CRAB criteria that we mentioned. So if you have a plasma cell of more than 10% and a patient has anemia, that is sufficient to diagnose that patient. Apart from that, also we have what you call the myeloma defining events. And if for whatever reason this patient has presented to the clinic, they don't have the CRAB symptoms, but they have a BMA that is showing a percentage of 60%, and you don't even have the CRAB criteria, that is sufficient, though that is usually very rare. Because by the time a patient has 60%, almost always what you call a focal lesion, which I had talked about in an MRI, of at least 5 millimeters or greater in size. This is very important, especially at those pre-malignant stages. You may pick this as the only guide that this patient actually can be started on treatment. And then the kappa to lambda ratio, if you have a speed ratio of greater than 100, it is sufficient to start that patient on treatment. So next slide. So this is just to remind us that we need to stage multiple myeloma. And for you to diagnose it, actually, we have almost everything except what you call cytogenetics. This is a revised international staging for multiple myeloma. And you need a serum albumin, which you'll be able to get from your liver function tests, and then a beta-2 microglobulin, if it is less than 3.5 milligrams per liter. If you're able to do cytogenetics, no high-risk cytogenetics, and then a normal LDH, that puts them at stage 1. And these patients, their 5-year survival is more than 82%. And then stage 3 is a serum beta-2 microglobulin of more than 5.5, and then a high LDH or elevated LDH, and then high-risk cytogenetics. So next slide. What we have done, we staged our patients for 2021, and you can see stage 1 was 7, and we only did the ISS staging. We didn't include this because we don't have the capacity to do cytogenetics yet, but it is work in progress. And stage 2 was 16, and you can see almost more than half of the patients were in stage 3, and maybe that is why we are diagnosing these patients, but at the same time, we end up losing almost more than half of them. Next slide. I'm almost done. I have just 3 more slides to go. This is a slide. Yeah, thank you. Just to show the experience of other people as compared to our experience. This is when you look at in the US, their median age for diagnosis was 69 years of age. And then from a study, this was one that was published in Lancet Oncology in 2021. And then look at Ghana, 58 years of age, Uganda, 59 years. And then this is from a review of a 10-year experience. That review was done for the patients who've gone through the multiple myeloma program, and the median age was 61 years. So you can see like the one for the US is 69 hours, is a little bit younger, 60 by almost 10 years, and therefore we cannot overemphasize. And if you are talking about African Americans being at higher risk, does that mean then that as a Black race we are at higher risk of multiple myeloma, and therefore we need to put more efforts on it? When you look at the presentation, bone pain is cutting across. And that's why we are saying bone pain is, sometimes when people get older, they are just saying, these bone pains I have, and you sort of tend to live with it, and you may not necessarily even go get checked. We are saying it could be multiple myeloma, go get checked. And then when you look at the median survival, we look at those who have been transplanted. At the beginning of my presentation, I mentioned that patients have there's been a great progress because of targeted agents and the role of stem cell transplant. And the median survival is about 8 years in the US, and we are talking about months, 33 months, which is just a little bit over 2 years in Uganda, in Kenya, and in Ghana. So what are we missing? What are we missing? We need to close the care gaps. Looking at the treatment, next slide. So when you talk about treatment, when this patient once you've been able to diagnose, you've staged, and the role of staging is mainly just to guide the patient towards the prognosis. It might not really impact on the choice of treatment per se, but more in terms of the prognosis. But once this client comes to you, you need to be able to determine whether they are transplant eligible or ineligible. And the eligibility of transplant depends on a number of things: the age of the patient, the older they are, then they are less likely to be transplanted. Then at the same time, you look at either comorbidities that they have, and then at the same time, and that you'll be able to define whether this patient is transplant eligible or transplant ineligible. Most of our patients, and then of course affordability, which is a big one here, because most of our patients are not able to afford, and apart from affordability, it's also availability. We don't have it, for example, it was recently introduced in Nairobi West Hospital. I think they've done almost 4 transplants, and therefore, but if they are not, most of our patients, actually 90% of our patients, are not able to go for transplant. So then what do? We give these patients chemotherapy. And their phases are what you call induction phase, and then maintenance. So we give induction chemotherapy of an average of 6 to 8 months. Then after that, the patients transition to maintenance therapy. And the medications usually are we have what you call botulism or proteasome inhibitors, which bortezomib, idazomib falls under there. Then we have steroids, which is dexamethasone and prednisolone. And then you can have also chemotherapeutic agents, which includes cyclophosphamide. And with that, you're able to give either a triplet or a doublet regimen. So in MTRH, we give bortezomib, lenalidomide, and dexamethasone, which is actually first-line treatment worldwide. And then we give it for 6 to 8 cycles, and use what we had mentioned in terms. You have to monitor these patients. You monitor using the lab parameters that we had mentioned: the serum protein electrophoresis, the serum free light chain assay, with an objective to get those levels to normal or 0. And then after that, the patient transition to maintenance, and we use lenalidomide for maintenance. Our new challenge is after that, what are our treatment options? Do we have the targeted agents? For example, daratumumab, which we don't have access to, but is work in progress. Just so that I leave room for questions, I will move to our last slide, which is multiple myeloma project ECHO. Are we on the last slide? Mm-hmm. Thank you. So this is in support of our continuous reaching out to healthcare providers, and this is a platform where we hold this every last Wednesday of every month, and basically we encourage. What happens is you come up with a case that you think either could be multiple myeloma or even a confirmed multiple myeloma, and you wanted to guide on it. So we would have a presentation from any of the any of the referring facilities, and then after that we usually have a didactic session on a unique topic, or not necessarily unique, even refresher topic on multiple myeloma. And this has been running for, this is now our 2nd year, And we've been able to really appreciate and continue to disseminate information on multiple myeloma and even increase the high index of suspicion. So you can reach out to that number for us for more questions on how to enroll in the Multiple Myeloma Project ECHO. And we are welcoming everyone who is in attendance today to be able to participate in this monthly session for us to continue demystifying management of multiple myeloma and moving it from to what the rest of the world, where the rest of the world is, which is it's actually now almost being considered as a chronic disease rather than a disease that has been causing a significant morbidity and mortality. Thank you so much, Dr. Wanda. I'll take it back to you. And,
thank you very much. Thank you so much, Dr. Beatrice Melly, for that presentation. We have really enjoyed to learn about multiple myeloma. There is a lot to gather. I can see so many applauses. You're getting bouquets, you're getting a tada, and even loves showing. People have really appreciated the knowledge that you've provided today. And there are quite a number of questions on the chat box that I think we can tackle now and discuss them so that those who ask the questions can have an opportunity to get answers to the questions that we've had. So one starts by saying, thanks for this educative session. I saw a 31-year-old male presenting with a history of fall, and he sustained a mid-shaft femur fracture. CT scan showed lytic lesions on the bone, suggestive of multiple myeloma. How common is multiple myeloma in young adults like this 31-year-old? You had alluded to it, Dr. Melly, but I think we can discuss that now.
Yeah, thank you to our colleague. So as I had mentioned, our youngest patient was 26 years of age. So definitely this 31-year-old, there's still a high possibility that it is multiple myeloma. I think maybe just opening up what else can cause lytic lesions. Was it male or female?
Male, sorry, male, 31-year-old male.
Yeah, there are other malignancies that can cause lytic lesions, but definitely we would really, the 31-year age does not leave these patients out. Our median age, when we looked at our 10-year data, was 61 years of age. We've seen quite a number of patients in their 40s, but at the same time, our youngest patient was 6 years of age. So definitely, that patient needs to be, you need to rule out that it's not multiple myeloma.
All right, thank you very much, Dr. Then there's a question when they're talking about the being more common in male, they're asking whether sex hormones like testosterone could be a contributing factor to multiple myeloma in males.
Actually, this is a question that keeps coming up. Why male?
Mm-hmm.
And even when we look at they said that, you know, the genetic aberrations that have been identified in multiple myeloma seems to be more in male. It's not clear whether there's a hormonal contribution to it. Mm-hmm. The thought process, which is really remote, is that maybe the risk factors are including whether we're talking about radiation, maybe depending on those days, we were talking about the work could have exposed maybe men more, but it's me, from my personal clinic experience, I see just many as men as women. So this is just after you pull the data, and the preponderance is just, you know, we're talking about three to 2. So it's not like very significant. And there are no definites why male more.
Okay.
Yeah.
All right. Then what happens if one skips medication like for 2 days? I think that's someone already on treatment. They want to know what would happen if they skip treatment.
We encourage and we emphasize consistency and compliance, because generally better outcomes in cancer treatment, and this is cuts across all cancer. Outcomes are better if you're consistent on treatment, because the way these drugs have been, because the drugs have different mechanism of action. When you initiate one, when the other one comes in, it's supposed to come and support a process that one of the drugs has already initiated. Having said that, there are situations where one may miss drugs. Sometimes you may experience side effects. Sometimes you can run out of stock. Sometimes the drugs may not be working, and we probably have to take you off medications. 2 days is short. Usually you would need to be a longer period for the impact, usually within usually second to third week. But at the same time, we cannot, we just have to say you have to try as much as possible, not because we work on schedules, and it is better for us when the schedules are kept. It advises also clinicians on when to move, knowing that you have been fully compliant on a treatment option that had been provided. Sometimes when we miss the medications, it also confuses the clinical team whether it worked, it did not work, because the treatment was not optimized.
Right. And then there was kindly, in the course of presentation, comment on the need of calcium supplementation in patients with multiple myeloma, despite having hypercalcemia. And I think in the same vein, maybe just touch on the herbal concoctions or any other supplements patients are on.
So when you're talking about calcium supplementation, so most of the time, actually, you have a significant, quite a number of those patients may present with hypercalcemia, and during that time we don't give any calcium supplementation. Supplementation might come in during when the disease is in control, and we are specifically targeting bone remodeling, because for bone formation you need calcium, and it is usually the clinician should have been able to track your calcium levels, whether they've gone back to normal. Then at the same time, actually, we've had patients even developing hypocalcemia, even in the process of treatment. That is when we give calcium supplementation. So right up front, if the levels are high, what we are targeting is actually to bring the calcium levels to within normal, and so you shouldn't be on calcium supplementation at that point. But that doesn't mean that you can never be on calcium supplementation. The clinical team should be able to advise, depending on having checked the levels, especially the orthopedic team. And I have to mention Dr. Wanda, which I didn't mention. Yes. Management of multiple myeloma is a multidisciplinary approach. I cannot overemphasize the importance of this. Usually you have the core clinical team, which is usually led by the hematologist, but then there are other adjuncts with orthopedics. We're talking about psychological counseling, palliative care, renal, cardiology. You need to open up so that you have a holistic approach towards management. So even the decision on bone remodeling, when we have partnered with our orthopedic team, we found that we have leveraged better, and patients are doing better. Now about concussions and herbal medicine, that's a question which I would say when you are on treatment, for the treatment options that are offered are treatments that have been tried and tested. They've been taken through a process of investigation to know that it worked in this group of clients, and these are the challenges or rather maybe side effects that were experienced, and it has been found to be safe or not safe. And that is why we use those medications with confidence. When the challenge with herbal medication is that there are no trials that have been done on it. You don't know what is the impact it's going to have on your body. And usually our biggest concern is the impact on your kidneys and on your liver. These two organs are very important in drug, what you call drug metabolism or drug removal from the body. So when you take other drugs in adjunct or this herbal medication, it might impact the function of these two very important organs. And then now we'll even have problems with the drugs that you are taking. You know, we've had clients taking both drugs at the same time. We've had clients dropping their medication and go back to herbal medicine, and then they come back with disease progression. So my message is I would really advise we avoid and move, and as much as possible, avoid use of herbal medication. There's also the food supplements, which sometimes confuse nutritional supplements, confuse patients. What about nutritional supplements? Some even, we've had patients go to these very expensive nutritional supplements, which they tell you that, you know, everything is in this wonder drug. And people are spending a lot of money buying those drugs and trying those nutritional supplements. And our general advice is that if in the team, multidisciplinary team, there is a nutritionist. A nutritionist should be able to advise you. And during this process of treatment, you need to invest a lot in your general health, and including your nutritional support, because chemotherapy has an impact on your nutrition in terms of what you're eating. I would just generally recommend that make sure you walk through all these multidisciplinary teams, and they will be able to advise better in terms of walking this journey.
All right. Thank you very much. Thank you very much for the wonderful audience that we've had, for the many questions that have come through. I'm seeing we are actually hard pressed for time. We're to stop at 3:30. I've seen other messages thanking Mr. Toom for expressing himself. Josek, thank you for the wonderful presentation. And I hope this will be practice changing. It will enable us to have a high index of suspicion. Let us think about multiple myeloma when patients come with back pain. Let's think about multiple myeloma when we see anemia. Let's think about multiple myeloma, even in the young, because we are seeing some patients are pretty young. And let's have the index of suspicion, and let's share this information with our other colleagues. And thank you very much. We look forward to seeing you for the next CME. Have a wonderful afternoon. Bye-bye.
Thank you, Dr. Wanda. Thank you from the Empath Multiple Myeloma team.
Thank you, Doc.
Thank you.